Hi there. So let's talk about the two tests of hearing, Weber's test and Rinne's test. Right. So we've said some of this earlier in the earlier lecture, but let me just quickly run through it. So yes, ideally a test should be carried out in a quiet room. You need to obtain consent before performing the test. You need to give you need to give clear instructions to the patient so that there will be no danger of misinterpreting the test. Uh, a tuning fork, right? Consists of what? The tines. Those are the prongs, the stem, and the foot plate. The foot plate is the base of the tuning fork. All right, and conventionally, the 512 hertz tuning fork is used, right? You could also use a 256 tuning fork, but generally most authorities agree that the 512 hertz is better. There are some reasons for it for this, but we're not going into that. And you hold the stem of the tuning fork between your thumb and first finger. Now you strike the tines on your elbow or knee. You don't want to use a hard object, right? As this may damage the tuning fork. Right. So once you've set the tuning fork vibrating, you now place the foot plate on the vertex of the head, right? Equidistant from both ears. You could also use other parts of the head, such as the midline of the forehead, the bridge of the nose, or the chin. So the important thing is that it's put at a location that is equidistant from both ears. All right. So these vibrations will be conducted through the skull and they will reach the cochlea. Now you now ask the patient if they hear the sound louder in one ear than the other. All right. So the patient might hear their hair louder in the left ear or in the right ear, or they may tell you that they can hear the sound equally in both ears. All right. So this picture demonstrates the technique. In this particular instance, the fork was placed in the midline of the forehead. All right. So let's now interpret the Weber's test. Okay, but before we interpret it, let me just say a couple of things. There are two ways by which sound gets to the inner ear. It could be by air conduction, right? When the vibrations of the sound waves, vibration of the sound waves through the air just passes through the air canal and eventually reaches the tympanic membrane and is now moved on until it gets to the inner ear. Or sounds, as I'm speaking, or environmental sounds is getting to you, the sound waves are impinging on the bone of your skull, right? On the bone of your skull. And we know that sound can travel through solids, right? Sound can travel through liquid, can travel through air, as during conversation. It can also travel through solids, right? But it will vibrate the molecules of the solid. So in this case, the sound waves will vibrate through the bone of the skull, and eventually that vibration gets to the inner ear. So that is bone conduction. The first was air conduction. All right. So now, from the earlier part of the lecture, we had already talked about peripheral deafness could be sensorial or conductive, or mixed, but we'll just stick with sensorial or conductive here. All right. So what happens now? A normal Weber's test there should be no lateralization, meaning that the patient should tell you that they can hear the sound equally in both ears, right? The sound is not lateralized. Okay. So, but let's talk about what happens in conductive deafness first. In conductive deafness, the sound is heard louder on the side of the affected ear, right? So we say that sound lateralizes to the affected ear, right? Whereas for sensorial deafness, sound is heard louder on the side of the intact ear. We say sound lateralizes to the intact ear, all right? Let me explain this too before I go to the last point. Now, why does sound why is the sound lateralized to the affected ear in conductive deafness, right? Why is the sound heard louder? Now remember that conductive deafness is just deafness basically caused by obstruction to the parts of the sound as it passes through the ear canal to on its way to the inner ear, right? And this when we say conductive, in this case we are referring to ear conduction, right? There is bone conduction and there is ear conduction, but when we just say conductive deafness without qualifying it. Basically, we are referring to ear conduction. All right. So conductive deafness is just a deafness that uh, impedes the that impedes air conduction, right, of sound to the inner ear. And what will impede air conduction is basically just obstruction. So for instance, if you have too much wax, if a patient has too much excess wax, right, excess cerumen within the ear, that will cause conductive deafness. Again, conductive ear deafness. Or if if you were to take a bath and water gets into your ear, right, for until the water dries off, or you are able to drain it off, then you are having temporary conductive deafness because the water is obstructing, right, air conduction into your ear. All right. Now the so why is it now that the sound lateralizes to the affected ear in conductive deafness? Now there is something called masking effect, because normally when you're having a conversation with somebody that is in front of you, right? uh, Normally the volume of your conversation is normally louder than the surrounding the environmental sound, right, the ambient sound, and that's why you can hear the your partner clearly. All right. So but this ambient here, so for instance, if you are sat in a room with many people, with many conversations going on, right, maybe in a lecture hall, right, you know that you notice that you often have to speak loud at a louder volume, right, before the person you are talking to that just in front of you can hear you clearly. Why is that? The reason is because these other sounds in the room, maybe from people, other if you're in a room in a hall that has 200 people, 200 students, there are many conversations going on. So that ambient sound will interfere with the ability of your hearing. It will interfere with the ability to perceive the sound, right, of the person you're having a conversation with, and so you need to raise your voice high, right. Now I'll give you another example. If you are traveling in a car that is moving at a moderate to fast speed, right, and the windows are open, right, this the sound of air rushing through the windows is so loud that for you to be able to have a conversation with people within the car, you need to raise your voice quite high. You need to raise the volume of your voice quite high. Now if you are to roll up your windows at that point, right, you roll up your windows and put on your air conditioner, right, because you have cut off the environmental sound coming from the air rushing through the windows, you find out that you cannot continue to speak at the same volume which you are speaking at which you are speaking earlier when the sound was rushing through the windows, because you will not find that you're actually speaking too loud and you need to bring down your volume. So it's quite clear that the environmental here was affecting your ability to perceive. All right. So what happens in conductive deafness is that since there is an obstruction in the ear, that obstruction will cut off a lot of the environmental sounds that would otherwise affect your ability to hear, right? And so you would hear the sound of the person talking, right? Mostly by conductive deafness, because mostly by conductive, uh, mostly by bone conduction, right? Mostly by bone conduction. So it's hair conduction that will be affected when there's an obstruction in the ear. So you can even try yourself. If you stick a finger in your ear, in one of your ears, stick a finger in your right ear to obstruct the ear, then speak to yourself. Now if you pay attention, if you are very careful, you notice that when you do that, that the what you are saying to yourself, that you can hear it a bit better in the sound in the ear in which you have stuck a finger into, right. Now when you stick a finger in that ear, you have temporarily caused a situation where there is conductive deafness in that ear. Yet when you speak to yourself, you are hearing the sound better in that same ear, simply because sticking a finger in that ear has cut off the masking effect of environmental sounds, right. And so environmental sound is not entering that ear by air conduction, but the sound is reaching, since I said do it in your right ear, the sound of you speaking is reaching your inner ear through bone conduction, right? And the boom, so and that sound, there's no masking effect from air conduction, so that's why you can hear it louder in the affected ear. All right. So whereas in sensorineural deafness, if you remember, sensorineural deafness is caused by issues with the cochlea, with the inner ear itself, or with the vestibular nerve. So, but in sensorineural deafness, right, the sound will lateralize to the intact ear, because that intact ear, the intact ear is ear that doesn't have any deafness. It will lateralize there because that ear does not have any issues with the cochlea. So that ear has a more healthy cochlea, and so that ear will hear it better than the hair that has an issue. All right. So, but there's a third scenario. It's possible to still have hearing loss, and Weber's test will not lateralize. Now, this will happen in the case of a bilateral and symmetric hearing loss of either type. So, say a patient has conductive hearing loss on both sides, and the degree of the hearing loss is about the same for the 2 years. Then that means in that particular scenario as well, there will be no lateralization. All right. So, but now, if we've now done Weber's test and we've discovered that there is lateralization to a particular ear, say the right, for instance, how do we now know whether that lateralization is due to conductive or sensorineural hearing loss? Okay, we'll talk about this shortly. So, but let's go back to the previous slide. Again, if there is, based on what we've said in this second and third bullets here, now if Weber's test lateralizes to the right ear, there are two possible scenarios. It's either you have sensorineural deafness in the left ear, right? Again, the sound lateralizes to the right ear. Now, it's either you have sensorineural deafness in the left ear, or you have conductive deafness in that right ear. Because based on these two things are these two statements here that are in bold, right? In sensorineural deafness, sound lateralizes to the intact ear. In conductive deafness, sound lateralizes to the affected ear. So, if we have lateralization in the right ear, is either we have sensorineural deafness in the left ear, or we have conductive deafness in the right ear. All right. So, how do we now know whether it is conductive or sensorineural hearing loss? For that, we need to do the Rinne test. Now, for the Rinne test, yes, you also use a 512 Hz tuning fork, but this time around, you put the base, the foot plate, on the mastoid process. That's the bony prominence just behind your ear. Right. And remember that for both Weber's and Rinne tests, you do the two procedures for the two tests for the 2 ears, one after the other. All right. So for Rinne test, you put the base of the tuning fork, on the mastoid process, right? And this test for bone conduction. Now, you confirm from the patient that they can hear the sound of the tuning fork, right? And then you ask them to tell you when they can no longer hear it. Now, when the patient now says they can no longer hear the sound, you now move the tuning fork away from the mastoid process and put the prongs, right? The pronged aspect of it, right? The tines, you place it in about 2.5 centimeters in front of the external auditory meatus. This is to test for air conduction. So this is what we're talking about. This is where you start with testing for bone conduction. Then once the patient says they can no longer hear the sound via bone conduction, you now place the tines just in front of the ear and test for air conduction. Okay. So if they say now if they can hear the sound, right, like after they stop hearing the sound via bone conduction, and you now shift to test for air conduction, if they can now hear the sound for a bit longer before they can no longer hear it again, then that suggests that air conduction is better than bone conduction. Alright, and okay, I've not said this earlier. In the normal air conduction is always better, should be better than bone conduction, right? The air conduction should be superior to bone conduction, right? And so this is what you see here now, so that if patients can still hear in the Rinne test, if patients can still hear the sound via air conduction after they can no longer hear it via bone conduction, right, then it means that air conduction is better than bone conduction. This is what you will see in a healthy individual, and is sometimes referred to as Rinne's test is positive. But if After they stop hearing the sound via bone conduction, you now shift to test for air conduction, and they still say they can't hear the sound again. Then in this second scenario, bone conduction is better than air conduction. That's what it means. All right. Now let's now talk about the interpretation. Okay, let's skip this couple of these few slides. Let's start the interpretation here. Let's start in slide 87 here. All right. So now let's interpret it. Now for normal hearing, right? Uh, if Weber's test does not demonstrate lateralization, i.e., the patient says they can hear the sound equally on both sides. All right. Now, if so, it means so in this particular instance, it's either the ears are normal or the patient has a bilateral and symmetric hearing loss. All right, bilateral and symmetric hearing loss. All right, so but if we're now to do a Rinne test, we should find out that air conduction should be superior to bone conduction in both ears. So once we have this scenario, air conduction is superior to bone conduction in both ears, then we say the patient has normal hearing. All right. So, but now let's talk about unilateral sensorineural hearing loss. Now, if Weber's test lateralizes to the unaffected ear, right? So, for instance, in the first example I gave, that the if Weber's test lateralizes to the right ear, right? Now, if it's a case of sensorineural hearing loss, right, it means that the right ear is the unaffected side. The right ear is the unaffected side in sensorineural hearing loss, and it will mean that the sensorineural hearing loss is in the left side. Sensorineural hearing loss will be in the left side if Weber's test lateralizes to the right ear. I think this is straightforward. All right. Now, for unilateral conductive hearing loss, in this particular instance, Weber's test will lateralize to the affected ear. All right. When you now do Rinne's test, right? Now we are still using the same example that the Weber's test lateralizes to the right ear. All right. So if it lateralizes to the right ear and you now do Rinne's test, right? Now remember that for conductive hearing loss, bone conduction will be greater than air conduction, right? And so this is what you have in that right here. And how do you determine this? Again, remember what we do in Rinne's test, that if the patients that after they stop hearing the vibration of the tuning fork when it is applied directly to their mastoid process, to their mastoid bone, right? And you now put the tuning fork in front of their ear, and they now say they still cannot hear the sound. Then that means that bone conduction is greater. All right. So this is what you will experience in that right ear, in the case of right conductive hearing loss. All right. So this is what you now have. All right. Now, the fourth scenario is if there is symmetrical, you have symmetrical conductive hearing loss. All right, so since this hearing loss is symmetrical, Weber's test would not demonstrate any lateralization. All right, Weber's test will not demonstrate any lateralization. All right, so then when you now do Rinne's test, you now find out that bone conduction will be greater than air conduction for the two ears. Since it is symmetrical, right? Bone conduction will be greater than air conduction, which is an abnormal situation, because the normal situation is that air conduction should be greater. So it means that for the two ears, they will after you remove the tuning fork from the mastoid bone and place it in front of the ear, for the two ears they will still not be able to hear anything again for the 2 years, and will be a case of symmetrical conductive hearing loss. Okay. All right. So basically that's it, and this table shows what we are talking about. All right. I think we'll end it here for now.